Welcome to this session. My name is Flavio Ribichini. I work in the hospital in Verona, in northern Italy. And it's a pleasure to be in this session, which is sponsored by Elixir Medical, because we are going to talk to something different. I mean, we have been talking about stents for more than 40 years, and stents have gone through a very interesting evolution, and I think that we will see results and we will see mechanisms that talk about a further evolution. The title of the session, you can see, Restoring Vessel Physiology Drives Outcomes, the Bioadaptor Experience. This is what we are going to talk about. With me, my spokesperson is Johan Bennett from the Netherlands, and in the panelists we have a very international representation, Dr. Mirvat Alasnak from Saudi Arabia, Michael Harvenek from Poland, Anthony Wong, and Ganat Palaniapam. So all the world is representative, especially if you think that I am Argentinian, so we have also a South American. I'm not good at football, but I'm good in cardiology. And I don't have conflict of interest on this. And why you are here? You are here to understand the unique design characteristics of the Bioadaptor. We assume that you don't know anything about this, so we will take time in these next 45 minutes to explain you why this device is different and is unique. The connection between biology of atherosclerosis and restoration of the vessel physiology and function is behind the results that you will see in a moment. We want to explain you or to help you understand the existing level of clinical experience around the world and how clinical decisions are made, and to know the patients and the lesions that can benefit most from this specific type of Bioadaptor therapy. And why is that? Why is that? Because I said we have been implanting stents for many, many years, but stents is not healing atherosclerosis. It's containing, in a certain moment of the history of the disease, what is causing a symptom. So you see these three lines. I explained these three lines. The highest one, the worst, is the event recurrence in 10 years when the patients were implanted a first-generation drug-eluting stent. So it's not that old. It's not bare method. It's already Cypher or Taxus. The other two green lines, they are not that far away. They represent the incidence of events in 10 years in patients that got both bioabsorbable polymers or permanent polymers. And you see that after 10 years, more than 40% of these patients did had another event. This is related to both the failure of the stent or the progression in the non-treated artery. But if we focus on the stent itself and we remove the progression on the non-target, you see that the difference is not that much. After 10 years, if you use last generation stent, we are talking about sirolimus and propofol-eluting stent or ceterolimus-eluting stent. So these are bioabsorbable or permanent polymer. The curves are identical. So it makes no difference whether you implant a stent with bioabsorbable or permanent polymer. In 10 years, you will have 40% of patients coming back with a stent-related event. So we are far away from healing coronary artery disease, and this is even worse if you have comorbidities. Among these comorbidities, probably the worst is diabetes. You see that the degree of events in medically treated patients is twice as high as in patients without diabetes and is even higher in insulin-dependent diabetes. You can see on the right graphic the difference at 15 years in between diabetic and non-diabetic. So this is the issue we're going to assess. And so to start with, I will invite my friend Dr. Bennett to explain us which is the rationale of this therapy.
So good afternoon. It's a great pleasure to be here today to discuss in brief the technology of the DynamX Bioadaptor and also share the current available evidence for its use. As you've very nicely heard from Professor Ribichini, there is an unmet need. So adverse events continue to increase beyond 1 year after implantation of a metallic stent. Why is this? Chronic hypersensitivity reactions, inflammation, foreign body stimulus, underexpansion, all these different things contribute, but perhaps we should look a little bit further To have normal function, you need to have normal flow, normal vessel motion, and this includes pulsatile flow. It includes normal shear stresses, a normal functioning in endothelial cells. So if we're able to return a stented segment to this, perhaps we could reduce the need for re-interventions in stents implanted. How can this be achieved? Well, perhaps the Bioadaptor has a way of achieving this. So for those who are not aware of this, the DynamX Bioadaptor consists of 3 helical sinusoidal strands of cobalt chromium, 71 microns in thickness. They're presented here by the 3 colors, as you can see on the left panel. They are connected by a specific unlocking elements mechanism, and they supply this longitudinal support for the stent. There's a double layer of coating involved. There's a top coat which elutes over 3 months, and it gives off sirolimus. And then there is this base coat, a bioabsorbable polymer, which holds together these unlocking elements for up to 6 months. When it resorbs, then you get unlocking of this device. So it has a unique mechanism of action, which is threefold. Acutely, it is a DES-like result with the locked system in place, establishing normal lumen flow and achieving high acute gain. With the resorption of the base coat, we then get unlocking elements of this device. So the 3 strands are unlocked from each other, restoring adaptive remodeling and whilst maintaining lumen flow and good lumen areas. Finally, there's a third phase where you get the restoration of pulsatility, compliance, adaptive dynamic coronary flow, and return of really normal vascular function. So this translates into better clinical outcomes. So what have we done so far? There's been 2 mechanistic studies in Europe and also in New Zealand, which have been published. The large and very important Bioadaptor RCT was presented last year here as a late-breaking trial and has also been published. And at present, the Infinity Sweetheart RCT with 2,400 patients being randomized between Bioadaptor or Onyx. The primary endpoint will be presented later on this year. So the results of those are also pending. There's also a registry which is ongoing in enrolling patients. If we have a closer look at the current RCT data we have, I'll remind you that this was a study where the Bioadaptor was compared to the Onyx in 445 patients. The primary endpoint was target lesion failure at 1 year, which was presented last year. And now we also have the 2-year results available. That was presented 2 days ago by Professor Saito. For the 2-year clinical follow-up, I want to just draw your attention that there is also a per protocol population has been evaluated, as there were 3 patients who had a protocol violation and 2 patients did not receive the standard therapy or were in the wrong arm. Looking again at some baseline characteristics, a high degree of hyperlipidemia, hypertension. The LAD was treated in most of these, in more than half of the cases. And you can appreciate the complexity involved as well. They weren't all simple lesions, but certainly a calcification, tortuosity, and bifurcations were present, with 1 in 5 having a B2C lesion morphology. These were the results, as I mentioned, presented last year. So it met the primary endpoint of non-inferiority for TLF at 1 year with a rate of 1.8% for the Bioadaptor compared to 2.8 for the Onyx. If you look at some interesting secondary imaging endpoints, you can appreciate there on the left side of the screen that immediately after implantation of the devices, Onyx and DynamX, you can see that in-device segment, there is very little in the way of in-device pulsatility. However, when we look at the 12-month follow-up, we can see here that in the in-segment treated segment for the Bioadaptor, there's a return to almost normal pulsatility, whilst of course the Onyx is caged and does not have this feature. This is how it looks. If you look at stationary OCT imaging, you can see the increase during systole and diastole, the change in blood volume, lumen area, due to the pulsatility returning to this artery. So how did this translate into results at 2 years? If you look at the ITT population, first of all, the TLF rate was 2.3% for the Bioadaptor compared to 5.5% for the Onyx. And when we move on to look at the Per protocol population, you can see significant reduction of 65% with a TLF rate now of 1.9% for the Bioadaptor compared to 5.5% for the Onyx. And again, in all the other cardiac MI, target vessel MI, clinical-driven TLR, the rates are numerically lower in the Bioadaptor DynamX group. Specifically looking at lesions which are at higher rate of restenosis, we know that the LAD has more torsional stresses upon it. With small vessels, of course, higher degrees of restenosis and long lesions. We can see here, specifically for the LAD, as it was a larger number of patients, a significant reduction in TLF rates in the LAD stented segments with a rate of 1.9 compared to 8.7 for the Onyx. So if I may conclude, I would suggest that this is the first technology with a novel design and proven mechanism of action that restores hemodynamic modulation, thereby driving this benefit in clinical outcomes. The outcomes at 2 years in the RCT study are very encouraging, especially the 65% reduction in TLF with further separation of the Kaplan-Meier curves present. And again, this almost flattening of the TLF rates between 1 and 2 years, again, also is interesting. For lesions, as I mentioned, which are a high risk of restenosis, especially the LAD, we saw a significant reduction in TLF, and also in the small vessel and long lesions, the event rates were lower for the Bioadaptor group. Thank you very much for your attention.
Thank you, Johan. A very nice introduction. You have now the elements to understand why this device is different to what we have been doing. There are two messages. This is one. The second is, if you want to make questions, I mean, you just connect to the app and we will be able to read your questions. Otherwise, much easier, all side, you go to the microphone and you make a question. But to get into the clinical practice and to see how this thing works, I will ask Mirvat to show one of the cases she has performed so that we have more human elements to discuss.
Yeah, well, thank you for giving us this platform to discuss this new technology. And it's very interesting. When it first penetrated our part of the world, there were the skeptics, of course, because they kept drawing parallel to biodegradable technology, and it's very different. And I think that that's the messaging that we ultimately need to show them. I don't have any relevant conflicts of interest. So this was a 46-year-old gentleman who presented with an acute coronary syndrome. He got the typical risk factors in our part of the world, diabetes and smoking. On presentation, he was hemodynamically stable and euvolemic, and an echocardiogram showed normal wall motion. His coronary angiograms, you see the right coronary angiogram there, dominant and effectively okay. So I'm just going to play this left system. So you see a very focal, tight critical stenosis of the LAD. This is probably his acute coronary syndrome, just before the bifurcation of a diagonal branch. The rest of the vessels look okay. So this is your lesion. We did intravascular ultrasound. As expected, the burden of calcification was limited. This was the tight lesion, and that was just the calcium that we saw. This was at the site of the bifurcation. Once again, you do see a little bit of calcium, but then you do see that small aneurysmal segment that was there. And then that was the small ectatic segment, very soft plaque even within that segment and just before it. So we went ahead and did our appropriate measurements at the different segments, looking at the both. You can see the EEL in these patients and appropriately size, proximal segment, proximal landing zone, distal landing zone, and so on. So the vessel prep, minimal calcium. We didn't need more than angioplasty, and then we identified the landing zones. So as usual, we wired both vessels just to protect the LAD, the diagonal, and maintain access. We pre-dilated the lesion, and as you can see, it yielded very nicely with just simple balloon angioplasty. We went ahead and positioned our stent, and it was a bit questionable. Should we, cover that small ectatic segment, which we opted to go ahead and do. just to make sure that we're covered. We did use, after we deployed the stent, we did proximal optimization and we did post-dilatation, again maintaining our wire in the diagonal branch, and subsequently you do see well expanded and opposed stent angiographically. We did compare the ostium of the diagonal to previous. And I don't know why these aren't playing. Okay. So this is the caudal view. Again, you do see a well-expanded stent, TIMI-3 flow. We went ahead with intravascular ultrasound, and we followed the stent back. No edge dissections, well-expanded. Again, that was the segment that had a little bit of calcification, some under-expansion. Went back, did a little more post-dilatation in this segment, and then you see that after we had better expansion of the stent in that segment. Why is this technology something that we want to be considering in our part of the world? Because, again, I showed you a patient who's very typical to what we see. You look at the risk factors, dyslipidemia, diabetes, and so on are very high on the list. Of all the Gulf Cooperation Councils, countries, 6 countries, Saudi Arabia has the highest rate of cardiovascular deaths, and about a quarter of the population have 3 risk factors, and a third of the population have 2 risk factors. And so it tells you that any technology that's going to preserve vascular function has outcomes. And again, it was very interesting to see the Bioadaptor results, 2 years outcome. So again, you're seeing results that are not only sustained to 2 years, but actually the Kaplan-Meier curves continue to diverge. So age of first MI of this patient was 46. Yeah. Thank you.
Thank you, Mirbad. Nice case. Any question from you? You use IVUS. I mean, is it recommended or required that you use intravascular imaging, or you can go with a balloon and stent like in a normal procedure?
So in this particular patient, we opted to do it because there was that ectatic segment. So I think it was important for us to be able to get the appropriate measurements and make sure that we don't undersize, but at the same time, we are sizing to the distal reference, and we don't want to end up with a complication where we're perforating. So I think it was wise in a case like this where the anatomy was not straightforward. For me, now we've started using it for about 6 months or so in our lab. I think you just size it just like a regular drug-eluting stent, so there's nothing tricky about it, to be honest.
Because we have the combination of a bioabsorbable part, which is the linkage in between the struts, and a part which is permanent cobalt chromium. Very thin, very thin. It's 70 microns, is it? 70. So, okay. So we don't need to confuse this with the absorb type, which has very thick struts, and intravascular imaging was making a difference. Here, this thing disappears and it gets embedded in the arterial wall, and it's not in contact with the blood anymore. So it's not necessary to use IVUS to guide implantation, as we used to recommend with the totally bioabsorbable scaffold, either the Absorb or the McMaris. Huh?
Agree, absolutely.
I also think that it is important, yes, that in this case you also show that the post-dilatation, yes, and I think it's also a tricky thing that these are detaching, struts, yes, and the post-dilatation is possible without any problems, yes. So it's in the acute state, there is no reason to detach by the balloons and post-dilatation these struts. So I think it's also important because you can treat it as regularly or treated with regular stents as we are used to.
Yeah, I think what really catches my eye is in your population of hyperlipidemia. I think this device can really have a synergistic effect with the lipid-lowering therapy. I guess they're all on statins, I imagine, there, and aggressively treated. But I mean, some data we couldn't show right now is the thought of lipid regression or even efflux, because you get this return to normal function or almost normal function in the vessel, which has been stented. So I think, does that make you excited about using this in your patients?
Absolutely, and I think patients like this who present with ACS, we are very aggressive with lipid lowering, and actually he is on injectable, so he is on was prescribed a PCSK9 inhibitor, and that would be an exciting area to look at, regression of plaque, lipid plaque.
Okay, we have a question from the floor.
It's about post-dilatation. As this stent, we would imagine Is there any precaution to perform a pot or a kissing? Is there a higher risk for deformation of this stent compared to regular DES?
No, I don't think there is. I think you have to obviously, keep it within the limits that have been advised by the company or, the FIFU. So there are two platforms. You've got the 6 crown platform, which goes up 2.5 up to 3, and then the 8 crown platform, which is a 3.5 and 4. And the smaller platform can go up to 4 millimeters, and the larger platform can go up to 4.5. So as long as you keep that in mind, you don't overexpand, then it's absolutely no problem at all.
Okay. Since you answered the other question, which is very interesting, that was made, any lesion in which would be contraindicated, this goes to you, and I will give the microphone. Who will answer that question?
Me? Okay. At that moment, of course, there is no issue in which we cannot use the stent. Yes, but as far as it is the first study, so it is always a little bit selected population. Yes, and we are all waiting for the Infinity Sweetheart trial, all comers, in which we will assess it in almost every scenario, including ACS, calcified lesions. And that will be published this year. But at that moment, there is no signal that there is a clinical or anatomical situation that this platform could work not well. Yes, so at that moment, I think we can have the same approach as in the other devices, just remembering about this, what Johan has said about this overexpansion.
I come from India, and we get young infarct of 25, 30, 32-year-old due to diabetes, obesity, and tobacco. Now, this technology will be very useful to us because now bioreabsorbable are not available. My question is, what exactly happens when this stent bioreabsorbable part is dissolved or is not more there? And what is the impact on dual antiplatelet in the management?
Okay. Johan, do you want to address that?
Sure. Yeah, so 2 questions. The first part is, so it's really only the base coat that resorbs. You don't get any polymeric breakdown products coming intraluminally. So the struts are fully covered, then it resorbs. The base coat resorbs, allowing the uncaging. So it's fully covered, so there's no risk in theory. Haven't seen any risk of thrombosis. In terms of DAPT, really, it is minimum 6 months DAPT. I'm sure that can be looked at as well in the future, but at the moment it's 6 months. Of course, for ACS, it'll be 1 year. I think for India, I think the combination of, this kind of technology with distal DCB might be something that would be very interesting.
It's perfect. Your question is very, very appropriate. So the big advantage is that when the links are bioabsorbed, the staff starts moving like not having this in the place. You still have the skeleton, but the artery gets its normal movement. And this might have very important implications in the long term of the regression of atherosclerosis. It is also, I think, important that the radial strand is still there, yes? 25% of the radial strand is still after the detachment, so the still keeps the vessel. So now I will invite Anthony Wong, to share his experience, because we were talking about potential contraindications for its use. You will see a very, very challenging case of a left main stenosis.
Good afternoon, everyone. First, I would like to thank my excellent panel for the kind introduction, and I would like to thank Elixir Medical for having me here. I'm Dr. Anthony Wong from United Christian Hospital of Hong Kong. We have learned that there's excellent data concerning the LCT of the bioadapters, and there are audience asking about whether we can have more applicability regarding different lesion subsets in applying this kind of bioadapter. So I'm going to share a case that we are actually going to adapt to more lesion subsets regarding the use of bioadapters, and one of those is the complex coronary lesion, which is the bifurcation. So here is my patient, who is a 58-year-old gentleman who is a chronic smoker with unremarkable past health. He suffered from hemodynamic unstable anterior STEMI, requiring inotropic support on admission. And this is the ECG. You can see there's a diffuse left main pattern ECG. The echo showed a very poor LV function with anterior septal echinacea. And so here's the baseline angio. There's nothing much to describe here. Basically, everything is gone. You can see there's acute left main occlusion here. Fairly unstable patient. So we do it careful wiring of the left main LED with a partial disengagement of the guiding. And we also by protecting the ramus and the circumflex with workhorse wires, and then do some pre-dilatation, and then we did the IFIS assessment, which confirms it's a true bifurcation Medina 111 lesions involving the left main LAD and circumflex artery, and with a diffusely diseased LAD downstream, as you can see from the IFIS here. So because of the emergency setting, our PCI strategy was to treat the left main lesions only, because we may need to stage the diffuse LED disease later on because of the emergency settings. And because of the Medina 111 lesion, we decided to use a dedicated two-stent technique at that time, which is a Cunard technique. But there's something different here is that we like to try to the efficacy, because it's also a young patient here, and we try to insert the bioadaptor in this time. First, we after all those wiring and lesion preparation, we insert a 28 millimeter, which is a small platform of the bioadaptor, this DynamX, to the left main cert, and we do the post-dilatation, the port of the stent, and then the LED rewiring. You can see there's a fairly easy rewiring of the side struct with this stent, with this bioadaptor platform. And then we do the struct opening with 3/5 NC balloons, and then do the kissing with 3/5 3/0 balloons. And then you can see from the clear stent here, the side struct is opening well here after kissing. So after that, it's just ordinary culotte stenting. We place another bioadaptor, which we intentionally landed proximal to the D1 takeoff, because we're afraid, we worry about the jailing of the diagonals. And then there's a 3/5 23 millimeter DynamX in Cunard fashion to the previous bioadapters. And then again, fairly easy rewiring, despite that we have double layer of bioadapters here. And then we do the post-dilatation, because there's also ramus here, we rewire the ramus, and then open the side hole to allow for avoid jailing of the ramus, and then we do the kissing, and then port with 4/5 NC balloon, and then the clear stent shows quite satisfactory and nice stent geometry, despite after all those complex stenting with this sort of bioadapters. Yeah. And then the IFIS confirmed that the bioadapter did expand quite well at the level of the bifurcation into LAD and circumflex, and at the distal left main at the overlapping segment. So here's the final results, and the angio was good. It was all side branches are preserved, and we have TB3 flow to all branches. We intentionally leave at this stage because of the emergency setting, because of contrast issue, patient stability issues, and the procedure time, and we decided to bring back the patient for stage procedure. At 6 months, you can see this despite that's maybe a problem with the outflow. You can see there's a mid-LAD lesion is not quite well treated at the INTERS procedure. The stent was still widely patent. Basically, everything was still there. And you can see we did the OCT we studied this time. You can see this very well expanded stent, not much significant ISR, I can say, and there's good healing of many of the structs, good endothelialization of most of the structs here. So as a stage procedure, we insert another bioadapter at the mid-LAD lesion. There's a 2/5 28 millimeters bioadapter to the mid-distal LAD. We did a minimal overlap here, as is the usual way we overlapping about adapters, because we try not to avoid overlapping segments. So to avoid overlapping the engaging elements as much as possible, so it can achieve its physiological purpose here. So here's a good, again, excellent final angiographic result. All side branch are here. So we highlighted clinical importance of managing acute left main myocardial infarction. Here is we highlighted our strategy to treat the culprit first, and then our ways of doing it to preserve the trifurcation left main strategy, the technical feasibility of bioadaptors in performing such complex two-stenting techniques. And we have experience in doing many cases with bioadapters, especially in STEMI setting, because of we are postulating the merits of this kind of stent is platform in treating patients with acute STEMI, because of the shrinkage of blood vessels due to vasospasm and underfilling during STEMI setting. That the insertion of the bioadapters may be able to allow for subsequent expansion, remodeling later on, so that we can avoid such, it may be possible to avoid so-called the malapposition issues later on. So we did an early follow-up OCT at 6 months due to clinical concerns here. We showed that there is satisfactory endothelialization, but the occasion, we have the stationary OCT there done at the time, but in the interest of time, I didn't put the images here because there's not much difference in pulsatility between systole and diastole by the time we did the OCT. So we're still eager we will bring back the patient in the future, and we're eager to see whether there's so satisfactory pulsatility later on, even in the setting of bifurcation stenting. So this might be the end of my talk. Thank you.
Thank you, Anthony. Impressive case. We will take the chance of your experience, and I will ask also Ghana to go straight with your case, so we discuss in the end the two cases. Sure. In the meantime, John, do you want to make a...
Yeah, in the meantime, I think there's a few questions here which are very pertinent to this case. One is left main PCI. Obviously, this was a left main PCI. I saw it was a 4.5 balloon. So for the 4.0 scaffold, 4.5 is fine. As somebody mentioned here very correctly, in Europe, most left mains are larger than 5. And in the meantime, we cannot really treat those. So in the RCT, there was no left main PCI. So hopefully the company will come up with a larger device so we can also include these patients.
Okay. And the other question is whether you can do the kissing under the diagonal. The answer is yes.
The answer is yes.
So we go with another fantastic case, and then we discuss the two together. Okay?
All right. Good afternoon, everyone. My name is Ganapati Palniappan. I'm from IGN, Malaysia. So the topic that we want to share today is hybrid method, where we use a bioadapter together with a DCB. I don't have any potential conflict of interest to declare. So my case happened to be another LAD case. So patient underwent a comprehensive assessment using a QFR, revealing 2 tandem lesions with TIMI2 flow. And we did further assessment with OCT with an interesting finding of honeycomb appearance. So we decided to go with the hybrid approach. The complexity of this case is in the long lesion of LAD, from the proximal up to mid-segment. So we want to avoid long metal stents, so we decided to go with a hybrid method. So mid-LAD was treated with drug-coated balloon, and the proximal LAD received a bioadapter. We achieved an excellent outcome, established a TIMI3 flow, and we'll share the OCT later. So the demographic, patient is a 42-year-old male, BMI of 32, hyperlipidemia, smoker. He was referred from a district hospital for non-STEMI. Angiogram revealed a severe 2-vessel disease, RCA and LAD. So we did the RCA first. This is the RCA. Severe mid-segment LAD and distal RCA extending into PD. So it's a subtotal stenosis. It took longer than expected. It wasn't easy. So we decided to stage the LAD. So this is post-PCI to RCA. Proximal to mid was stented, and the distal was treated with drug-coated balloon into PD. All right. Our case interest is in LAD. So this is the angiogram showing the LAD. The caudal view showing the proximal segment of the LAD diseased. Spider, we can see the LAD proximal lesion better, and the AP view. So the second lesion is actually even seen better in the RAO view. This is the RAO view. The mid segment here is also diseased compared to the proximal. So we did a QFR. QFR revealed 2 tandem lesions. QFR value was 0.62. And we proceed with OCT. This is the mid-segment lesion. The titus and the lumen size is The vessel size is 2.75 at the mid-segment and 3.0 to 3.25 at the proximal segment. This is the honeycomb appearance which is appearing here. And further continue up to the proximal LAD. So it means there's an event happened here. So the honeycomb is actually referring to a characteristic of vascularized, recanalized thrombus. All right. So we prepare the vessel with a cutting balloon 2515 from the mid-segment up to proximal. And this is post-predilation. You can see there's some recoiling at the proximal segment. And we treated the mid-segment with DCB paclitaxel elutimilin 27525. This is the placement of bioadapter. The bioadapter was placed in caudal view up to the ostium of LAD. And we deployed the bioadapter 3032 at 10 ATM. This is post-deployment. We establish a good flow, and we further post-dilate the vessel with 325 NC 32515 maximum at 20 ATM. This is the final results: caudal view, epicranial, and areocranial. We establish a beautiful flow up down to the telemetry flow down to the LAD. OCT assessment was done, and the QFR post PCI was also done. The QFR was 1.0, and the OCT post PCI shows some dissection at the mid segment. That's the area we treated with DCB, and the proximal segment stent is proximal segment bioadapter scaffold is well expanded and opposed to the vessel wall. So the clinical importance that we want to highlight here is the patient is a young patient, so he's only 42. So he still have another 20 years down the line, he might be having another lesions. He must be able to undergo bypass if it is necessary. We don't want to put a long metal stent in the mid-segment of the LAD. End up, he won't be able to go and do anything else. So further that, we ensure that the vessel motion is preserved. There will be pulsatility and vessel motion preserved. And in the event of positive remodeling, when the scaffold uncages, it will be able to help to avoid the late stent malposition. So the important technique here, IVUS, is very important because you want to size the vessel size, the size of the stent properly. You have to remember there is an appropriate scaffold sizing and post-dilation limit that we have to follow here, and make sure that we have prepared the vessel optimally. So the most important thing is you will be able to maintain long-term resolution capability of the vessel. Yeah, thank you.
Thank you. Join us in the panel because there will be, for sure, many questions to the cases. Johan, did we get questions from our colleagues?
Yes, there are quite a few questions coming through here. So I guess one, just to cover, was a moment ago, is regarding heavily calcified lesions. Of course, they were not really evaluated in the randomized control trial as yet. We would expect if you do appropriate lesion preparation, aggressively, make sure that your balloons are opening, using atherectomy if required. Perhaps this could be useful. I do think that this device, this kind of technology is most really useful in the cases we have seen, I think, today. Diffuse lung disease, LADs, young patients, hyperlipidemia. I think those are the ones we should focus on first, and then maybe build upon that to look at the more complex patients. I'm not sure what your thoughts are, Professor Bihini.
I agree. I wonder, especially the colleagues from Asia, that they have this diffuse disease in small vessels, as in India. Do you have already experience with mid to long-term angiographic follow-up of your patients?
Yeah, actually, we seldom use, just like Dr. Bennett said, we seldom do this insert bioadapters in severely calcified lesions because they're usually older patient and may defeat the benefit of the encagement of the vessels. But we did a few. I think we have still a registry in our local health center that we insert this kind of bioadapters in the CTO patient. Those require long stenting, diffuse stenting. Again, we do the minimal overlap in those lesions, but we do not have the follow-up angio data yet. Yeah, but the immediate result was good.
Mm-hmm. All right. So basically, from our side, we never attempted in a calcified patient, but saying that the 2-year study which we shared earlier, they included calcified vessel as well. Approximately 20% of the patients has calcified vessel. So that's why I put the highlight there, that it's important for you to prepare the vessel properly and then you deploy the stent. It should be okay.
Mm-hmm. Any other question from you?
Yes, can I ask a question?
Yes.
Regarding the overexpansion and post-dilation limits, what are the post-dilation and overexpansion possibilities with this platform? And what are the available sizes?
I think they just shared earlier.
Yeah, I'll just briefly, so the sizes are 2.5 up to 4.0. And there's two platforms. There's a 6-crown platform, which is up until the 3.0 device. And then there's a 8-crown platform up to for the 3.5 and 4. So the smaller platform can go up to 4. So the 2.5 and 3 can go up to 4, whilst the 3.5 and 4 go up to 4.5. Now, of course, that's very safely IFU recommendations, but I imagine it can probably go a little bit higher than that, but that's what they recommend at present.
So 4.5 is the larger side. Yeah. I have blown the stent up to. So.
Yes. How will you behave this stent in a band, in a 45-degree or 90-degree? How will behave the stent in a band, 45, 90 degrees?
Well, that's a very good question, I think, because I think the nice thing about this, you get return of the normal curvature of the vessel once you get, uncaging of the vessel. I'm not sure in your experiences in the long vessels in your countries, have you seen this happen? But I think you don't get this rotational stress on the stent, and you get a return of the normal vessel curvature.
So I think that is potentially one of the advantages of this kind of a platform. So I actually presented a case at TCT where it was a tortuous, obtuse, marginal, and circumflex, and it conforms nicely to the vessel wall. I actually did bring the patient back, not because of symptoms, but because I was trying to do a study looking at OCT and trying to teach myself how to actually look at, the bioadaptation that happens once it's completely uncaged. And you do see better motility. We've all put long stents, and you just see that it becomes rigid. You do start to see the vessel conform because the struts that remain are actually thin, and you've just lost that quote-unquote relatively bulky cage that was there. So it's single case, but it was very impressive in tortuous long lesions.
So we are approaching the end of this session. So in the interest of our expert, but also of the industry, I want to make 2 questions. Who was aware about this product? This product was presented last year at a late-breaking trial. It's a head-to-head comparison to one of the best stents, which is Medtronic. Who were aware about the existence of this? So less than half. And according to what you have seen, who really thinks that this might be a step forward compared to conventional stenting? So we still have to work. Which is fair, which is very, very reasonable. But of course, all the bases are promising. And so my take-home message will be very simple. Drug-eluting stents still have unmet needs. This is what I show you in the first slide. There are poor long-term outcomes, especially in those patients living longer. I mean, more than 10 years, you see 40% of recurrences, and there is no plateau at 2 or 3%. And these event rates are very relevant in the long run. The DynamX Bioadaptor technology maintains this fluid lumen and restores hemodynamic modulation of the artery. And yesterday, the 2 years results of the randomized controlled trial comparing this device with Resolute Onyx have shown clinical benefit, establishing what is a potential new standard for treatment of atherosclerosis, in particular in these patients that have long lesions where there is more risk of restenosis, LAD, which is the longest vessel, so sometimes you need more metal, and is, of course, prognostically the leading vessel for human beings. And the 2 things together, long lesions, small vessels, young patients, are, of course, a need that we still have to address. I took the liberty, because it's my style, to include a slide which is not in the set of the sponsor. I created this slide yesterday because it's my thinking. I mean, I am keen on leaving nothing behind. And the extreme leaving nothing behind is drug-eluting balloons. There is no polymer, there is no scaffold, there is just some dissection, and we know it's an excellent therapy when you want to avoid permanent caging. In the other side of the spectrum, you have the full metal jacket. I mean, if you metallize your artery, you are not healing atherosclerosis. What you are doing is precluding any kind of eventual intervention. So I think it's clear that full metal jacket is making things even worse. In the meantime, you can have reasonable stenting. This is what we promote. Stents are necessary, especially in, as we said, bifurcation, calcified lesions. And we still have ongoing work with bioabsorbable technologies, either the type of PPLLA or magnesium. In the middle, I see this device. Bioadaptor is not leaving nothing behind, it's leaving what is essential. So I think it's a concept we have to consider because it's different. It's not a full metal stent, it's not a totally biodegradable device, it's not drug coating balloon. But it's something new, and this is what we wanted to tell you. And what we saw at 12 months, the late lumen loss in patients, even including diabetics, is lower. There is a strong tendency of a lower late lumen loss compared to Onyx. These differences are, of course, driven from small observations, but the most important information we came to learn, I think it was yesterday when the randomized trial was presented with a prolonged follow-up at 2 years, there is a significant reduction on events. Target lesion failure, 78% lower, a total of less than 2% compared to 8.7%, which is exactly what we expect from Resolute Onyx. So it's not that the control group has more events, it's that this one has surprisingly significantly less. With a trend, of course, also a trend in favor in small vessels and long lesions. So this is what we had to share with you. I hope this has been useful, at least to raise your curiosity about a new device, which is potentially a step forward in our percutaneous treatment. Thank you for your attention and have a good afternoon.